Welcome back to the deep dive. I hope you're ready to roll up your sleeves today because we are doing something a little different. Usually we're dissecting business trends or, unpacking historical mysteries, but today we are getting under the hood of the human machine. We're looking at the plumbing.
That is a very apt, if slightly unglamorous way to describe it, but you're right. We are looking at the pipes that keep the entire system running.
Specifically, we are diving into Chapter 61 of the Absolute Bible of Surgery Baily and Love's Short Practice of Surgery, 28th edition. The chapter is titled Arterial Disorders.
Oh.
Now, before you hit pause, because you think we're about to read a medical textbook at you for 40 minutes, let me clarify our mission here.
Right, and that's so important. The goal here isn't to replace the book. If you're a medical student or a surgical trainee, you still absolutely need to read the chapter. You need the fine print, the diagrams, the specific dosage algorithms. Our goal today is to offer an interpretation. We want to take these dense, high-stakes concepts, stenosis, occlusion, ischemia, and translate them into mental anchors that will actually stick.
Exactly. Think of this as your ready reckoner. Whether you're prepping for rounds or you're just someone insanely curious about how the body fails and how surgeons fix it, this is for you. We are going to use metaphors, we're going to use case studies, and we're going to make sure that when you hear a word like claudication, you don't just know the definition, you feel the mechanism.
And we should probably set the stakes right up front. I mean, we aren't talking about obscure, rare diseases here. Arterial disorders are the most common cause of morbidity and early death in Western society.
Usually, though, when we hear that stat, we think about the heart. We think about the widowmaker heart attack, or we think about the brain and strokes.
Precisely. But the pathology, the root cause, is exactly the same. It's atherosclerosis, it's plaque. Chapter 61 just shifts the focus from the heart and brain to the peripheral system, the legs, the arms, the viscera. If the pipes clog in the heart, you get an infarct. If they clog in the leg, you get gangrene.
The mechanism is the same, only the location changes. Okay, so let's map this out. We're going to track the lifespan of a failing artery. We'll start with the slow burn chronic disease. Then we'll play detective and look at how we investigate it. We'll talk about how to fix it, lifestyle, drugs, and cold hard steel. And finally, we'll look at the nightmare scenarios, acute emergencies and gangrene.
Sounds like a solid plan.
Okay, let's start with the basics. The slow burn, chronic arterial stenosis and occlusion. What is actually physically happening in the pipe?
In the vast majority of cases, we're talking about atherosclerosis. This is plaque buildup. It's calcification. To visualize this, I want you to imagine your artery is a highway, a nice, wide, 4-lane interstate.
I love a good highway metaphor. Let's ride with it.
So in a healthy artery, you have this 4-lane highway. The cars are your red blood cells carrying cargo oxygen to the city, which is your muscle tissue. In a healthy state, traffic moves at 70 miles an hour. It's smooth. It's what we call laminar flow.
And comes atherosclerosis.
Right. Plaque. Think of plaque as road construction. A concrete barrier gets dropped in the left lane. That's stenosis and narrowing. Traffic slows down a bit, maybe merges, but it still gets through. But if you put barriers across all 4 lanes, that's an occlusion. The road is closed.
Now, here is where the concept of time becomes absolutely critical. The text makes a huge distinction between an acute blockage and a chronic one.
It's the most important concept in the entire chapter. I mean, if I shut down the interstate right now, instantly, without any warning, what happens?
Absolute chaos, gridlock, nobody gets to the city. The city runs out of supplies immediately.
Precisely. That is acute ischemia. The body is completely unprepared. But let's say I'm the Department of Transportation, and I slowly close down 1 lane a year over 10 years. What happens then?
The drivers get smart. They find side streets. They take the back roads through the neighborhoods to get around the blockage.
And that is exactly what the body does. It's called collateral circulation. You have these tiny dormant vessels that were previously, useless. But as the pressure builds up behind the blockage, that pressure gradient forces blood into these tiny channels. They dilate, they enlarge, they spiral around the blockage.
Nature's detour.
Exactly. Now, these side streets aren't as efficient as the highway. You can't do 70 miles an hour on a neighborhood street. But enough supplies still get to the city to keep it alive. The tissue survives.
That concept of side streets essentially explains the first major symptom the book highlights, intermittent claudication.
It really does. And claudication is a great word.
It sounds impactful. I learned that it comes from the Latin claudicare, which literally means to limp.
And there's a historical nugget there, isn't there?
Yeah, apparently the Roman Emperor Claudius was famous for his limp. Now, historians think he might have had cerebral palsy or maybe polio, not vascular disease, but the term claudication stuck for this specific vascular limp.
The mechanism of that limp is just pure supply and demand. Stick with the car analogy, but let's look at the engine this time. Your calf muscle is an engine. At rest, idling at a stoplight, it burns very little fuel. Even with narrowed arteries, those side streets we talked about, there's enough blood flow to keep the engine idling. You feel totally fine sitting in a chair.
But then you start walking, you step on the gas.
The engine revs. The metabolic demand just shoots up. The muscles are screaming for oxygen to burn energy. But the pipe is blocked. The supply is fixed and cannot meet the demand. So the muscle is forced to switch its fuel source. It goes from aerobic metabolism using oxygen to anaerobic metabolism.
And the byproduct of anaerobic metabolism is lactic acid.
Bingo. The tissue becomes acidic. It creates metabolites that irritate the nerve endings. It hurts, it cramps, it feels heavy. The patient starts to limp.
And the only way to clear that acid is to lower the demand.
You have to take your foot off the gas. You stop walking. You just stand still. The demand drops back to idle levels. The trickle of blood flow from the side streets catches up, washes out the acid, and the pain vanishes. Usually this whole cycle takes less than 5 minutes.
Now, this is a huge clinical differentiator, isn't it? Because lots of people have leg pain. How do you, as a clinician, or even, as a patient, tell the difference between my arteries are blocked and my back is bad? Because spinal stenosis is also very common.
This is the classic board exam question. You have to distinguish arterial claudication from spinal stenosis, which is sometimes called neurogenic claudication. The key is what relieves the pain. We call it the shopping cart sign.
The shopping cart sign. Break that down for me.
Think about the mechanics. In arterial disease, the plumbing issue, it's purely about muscle work. If you stop walking and just stand still, the muscle stops working, demand drops, the pain goes away. You don't need to sit. You just need to stop moving.
Stop and stand. Got it.
But in spinal stenosis, the nerves are being pinched in the spinal canal in your lower back. Standing up straight actually extends the spine and narrows that canal further, pinching the nerves more. So standing still actually hurts these patients. They need to flex their spine to open the canal. They need to sit down or bend forward.
Like leaning over a shopping cart in the supermarket.
Exactly. If a patient tells you, I can walk around Walmart for an hour as long as I'm leaning on the cart, that is almost certainly their back, not their arteries. If they say, I have to sit down on a bench for 10 minutes before I can move again, think spine. Vascular pain clears up fast, 2 to 5 minutes of just standing there.
That is such a useful heuristic. So stop and stand versus sit and wait?
Correct. Now, there's another specific pattern of claudication mentioned in the text called Laurentius syndrome. This is for blockages way up high in the aorta or the iliac arteries, right where the aorta splits to go to the legs.
And it has a classic triad of symptoms.
It does. 1, buttock claudication. The pain isn't just in the calves, it's in the glutes and thighs because the blockage is upstream of the whole leg. 2, absent femoral pulses. You can't feel a pulse in the groin because the road is closed before it even gets there.
And the third one is the kicker.
Sexual impotence in men. Specifically, the inability to maintain an erection.
Because the internal iliac arteries supply the inflow for that mechanism.
Exactly. It's a powerful reminder that vascular health isn't just about leg pain. It's about identity, independence, intimacy. When the plumbing fails, it affects the whole human experience.
So we have claudication. The patient walks, hurts, stops, recovers. But what happens if the disease progresses? What if those side streets start getting blocked too?
Then you move from the warning light stage to the critical failure stage. We call this rest pain.
The supply is now so low that it can't even support the engine at idle.
Correct. The muscle is starving even when you're just sitting on the couch. But there is a very specific nuance here regarding gravity. The book calls it the gravity factor.
Right. Why is rest pain always worse at night?
It comes down to pure physics. During the day, you're upright. Gravity is helping pull that blood down the leg, squeezing every last drop of perfusion pressure into the foot. When you lie flat in bed, you lose that gravity assist. The perfusion pressure drops just a few millimeters of mercury, but in a critically blocked leg, that's enough to tip the balance. The tissue starts to suffocate.
So the patient wakes up in agony.
Usually a gnawing, burning pain in the toes or forefoot, and what do? They figure out intuitively that if they hang their leg out of the bed, it helps. Or they start sleeping in a recliner chair.
Restoring the gravity assist.
Exactly. If you walk into a patient's room and see them sleeping in a chair, or they tell you, I haven't slept in a bed in 6 months because of the pain, alarm bells should be ringing. This is critical limb-threatening ischemia, or CLTI. This leg is actively dying.
Let's talk about what that leg actually looks like, the physical signs. There's a description in the text of the sunset foot.
It's the most poetic description in vascular surgery, which is saying something. It refers to a clinical test called Berger's test. Here's what you do. You have the patient lie down and you lift their leg up high to about 45 degrees.
You're draining the blood against gravity.
Right. In a healthy person, the foot stays pink because the pump is strong enough to push blood uphill. In an ischemic patient, the pressure is so low that gravity overcomes it. The blood drains out completely. The foot turns a cadaveric, pale white. We call that exsanguination.
Like a ghost foot.
Then you have the patient sit up and swing the legs over the side of the bed. Now gravity rushes the blood back in. But here's the catch. Because those tissues have been starving, the tiny arterioles are maximally dilated. They are gaping open, trying to catch any molecule of oxygen. So when the blood returns, it just floods the tissue.
And the foot turns bright red.
A deep, angry purple red. We call it dependent rubor. So pale went up, red went down. The sunset foot. If you see that, you know the circulation is critically compromised.
You also check capillary refill, right? The toe squeeze.
Always. Squeeze the toe for 5 seconds until it goes white, then let go. A healthy toe pinks up in 2 or 3 seconds. In these patients, it might take 10, 15, even 20 seconds. It's like watching a slow-motion video.
And pulses, obviously.
Comparison is everything. Compare left to right. And here's a little nugget. If you feel a booming femoral pulse in the groin, but the popliteal pulse behind the knee is gone, you have a blockage in between. But if the popliteal pulse is huge, like too easy to feel, be careful. That might be an aneurysm, a ballooning of the artery.
Okay, I want to pause here for a second. We've covered a lot of physiology. Let's do a quick mental check-in for everyone listening.
Well, let's do it.
Listener, picture a patient. Let's call him Bob. Bob comes in and says, "My calves hurt when I walk to the mailbox, but I have to sit down on the bench for 10 minutes before it eases off. Just stopping and standing doesn't really help. I have to sit." Based on what we just discussed, is Bob likely suffering from arterial claudication?
Pause and think.
The answer is likely no.
Right. The key clues were need to sit and takes 10 minutes. Arterial patients recover fast, usually within 5 minutes, and just need to stop moving. Bob likely has spinal stenosis. He needs a spine surgeon, not a vascular one. Rewind if you aren't sure why, because that distinction is absolutely key.
All right, let's move to section 2. The detective work. We've examined the patient. We suspect a blockage. How do we prove it?
We start at the bedside with technology, the Doppler ultrasound. This is that little handheld wand that looks a bit like a microphone.
We've all seen it on TV. It makes that whoosh sound.
Yes, but you have to really listen to the quality of the whoosh. A healthy artery has a triphasic signal.
3 phases.
It goes whoosh. Phase 1, the heart pumps, big forward flow. Phase 2, the vessel is elastic, it snaps back, giving a Brio reverse flow. Phase 3, forward flow settles, whoosh up. It sounds sharp, crisp.
And a sick artery.
As the vessel hardens and narrows, it loses that elasticity. You lose the rebound. It becomes biphasic. And if it's really blocked, it becomes monophasic. Just a flat, continuous, low-pitched whoosh. It sounds like wind howling through a tunnel.
That leads us to the ABI, the ankle brachial index. This seems to be the gold standard number.
It is. It's simple math. You take the blood pressure at the ankle and you divide it by the blood pressure in the arm. In a perfect hydraulic system, they should be the same. So the ratio is 1.0.
What are the cutoffs for disease?
Anything below 0.9 is abnormal. If you're in the 0.5 to 0.9 range, that usually correlates with claudication, the limping we talked about. If you are below 0.4, that is critical ischemia. That leg is in serious trouble.
And this is a massive, but the text highlights, there is a trap here, specifically for diabetic patients.
The diabetic trap. This is crucial. We mentioned plaque atherosclerosis, which is on the inside of the pipe. But diabetics also get a different pathology called medial sclerosis. This is calcification of the middle muscular layer of the artery wall.
It turns the artery into a lead pipe.
Literally, it becomes rigid, incompressible. So when you wrap that blood pressure cuff around the ankle and pump it up,
you can't squash the artery close.
You just keep pumping. 200, 250, 300 millimilli Hg. The Doppler is still singing. The computer calculates the ratio and gives you an ABI of 1.5 or even higher.
So the computer says super healthy, but the patient actually has gangrene.
It is a very dangerous false negative. If you see an ABI above 1.4, you have to assume the test is garbage.
So what's the workaround? What do you do?
You go distal. For some reason, the tiny arteries in the toes rarely calcify like the big ones do, so you use a tiny cuff on the big toe, the toe brachial index, or TBI. That'll give you the truth.
Okay, so we have the bedside numbers. Now we need pictures. We need a roadmap of the blockage.
We step up the ladder of imaging. Rung 1 is duplex ultrasound. It uses sound waves to visualize the flow and color. It's safe, non-invasive, and cheap.
But it has limits.
Oh yeah. Sound waves don't travel well through gas or fat. So if you're trying to look at the iliac arteries deep in the belly and the patient has gas or is obese, the ultrasound just sees fog.
So you bring out the heavy artillery, CTA and MRA.
CT angiogram CTA gives you beautiful high-res 3D reconstructions. Surgeons love them. It's like Google Earth for the arteries. But it requires radiation and it requires iodinated contrast dye.
Which can knock out the kidneys.
Exactly. Contrast and nephropathy. If the patient already has kidney failure, which, a lot of vascular patients do, you just can't use it.
So you use MRI.
MRA, magnetic resonance angiography. No radiation. But it has its own contrast issues with gadolinium, and you have to put a claustrophobic patient in a loud tube for 45 minutes. Plus, if there is a lot of calcium, MRA tends to bloom. It overestimates the blockage. It makes it look worse than it really is.
And finally, the old school gold standard, DSA, digital subtraction angiography.
This is invasive. This isn't just a scan. It's a procedure. You use the Seldinger technique. Needle in the groin, wire into the artery, catheter over the wire. You inject dye directly while taking an X-ray movie.
It gives the best pictures, but you wouldn't do this just to diagnose, would you?
Rarely. Because you're already in the artery, you usually reserve DSA for when you plan to fix the problem at the same time. We call it shoot and dilate.
Which is the perfect segue to Section 3. Fixing the plumbing. We know where the blockage is. What do we do?
The most important takeaway from this chapter might actually surprise you. The first line of treatment for claudication is usually nothing surgical.
Wait, really? The pipe is blocked and we don't unclog it.
We don't, because the natural history of claudication is actually quite benign. The risk of losing the leg is less than 5% over 5 years. The real risk for these patients isn't the leg, it's the heart and the brain.
Atherosclerosis is a systemic disease. If it's in the leg, it's in the coronaries.
Exactly. These patients are far more likely to die of a heart attack than they are to undergo an amputation. So the treatment is risk factor modification.
Lifestyle is medicine.
The prescription is simple, but it's brutal. Stop smoking and keep walking.
Keep walking, but walking hurts. That's the whole problem.
It does. But a structured exercise program walking through the pain for 30 minutes a day is incredibly effective. It forces those collateral vessels to open up. The sheer stress of the blood flow signals the body to remodel the vasculature. It's basically natural bypass surgery.
And drugs.
Statins, high dose. Not just to lower cholesterol, but to stabilize the plaque so it doesn't rupture. Antiplatelets like aspirin or clopidogrel to prevent clots. And, of course, controlling blood pressure.
There's a note about beta blockers in the text. I've always heard they are bad for peripheral vascular disease because they squeeze the vessels.
That was the old dogma. The theory was that beta blockers constrict the peripheral vessels, so they would make the leg flow worse. But the text corrects this. It says the benefit to the heart preventing that heart attack vastly outweighs any tiny theoretical risk to the leg. So don't stop the beta blockers. The heart trumps the leg.
Okay, let's say lifestyle isn't enough. The patient can't work, or worse, they have rest pain. We need to open the pipe. We have two main flavors, endovascular versus open surgery.
Endovascular is the keyhole approach. This is the realm of wires and balloons. We navigate a wire across the blockage, then we slide a balloon over the wire angioplasty. We inflate the balloon to 10 or 12 atmospheres of pressure. It cracks the plaque and squashes it against the wall.
But plaque is elastic. Doesn't it just spring back?
It can. That's called elastic recoil. So usually we place a stent, a metal scaffold.
Like a spring inside the pipe.
Exactly. We have balloon expandable stents for rigid areas and self-expanding stents made of nitinol, a memory metal, for areas that move and twist, like behind the knee.
There's also a really cool technique described called subintimal angioplasty.
This is such clever engineering. Sometimes the plaque is rock hard. You can't get the wire through the center, through the lumen. So the surgeon deliberately pushes the wire into the wall of the artery itself.
Into the wall?
Between the layers, between the intima and the media. They tunnel through the wall, past the blockage, and then break back into the mainstream on the other side. They essentially create a new pipe within the wall of the old pipe.
That is wild. But sometimes the keyhole isn't enough. You need the bypass.
The open surgery. This is plumbing 101. If a pipe is blocked, run a new pipe around it. If the blockage is high, in the aorta, you do an aorta bifemoral bypass. You sew a synthetic pair of trousers, usually made of Dacron, from the aorta to the groin arteries. It's a massive operation, but it works very well. 90% are still working after 5 years.
And for the leg, the femoropopathial bypass.
Here, the text has a golden rule that every surgeon knows by heart. Vein is king.
Vein is king. Explain that.
You need a conduit. You can use a plastic tube like PTFE or Gore-Tex, or the patient's own vein, usually the great saphenous vein from the inside of the leg. The patient's own vein has a living lining called the endothelium. It secretes chemicals like nitric oxide that prevent clotting. It resists infection. It just lasts way longer than plastic.
So you harvest the vein from the leg, flip it around so the valves don't block flow, and sew it in.
Precisely. If you have a good vein, you use it. But sometimes the patient doesn't have one. Maybe they had it stripped for varicose veins years ago.
So then you have to use plastic.
And if you use plastic, there is a brilliant surgical trick called the Miller cuff.
What is that?
The problem with plastic is that it's stiff. If you sew stiff plastic to a soft artery, the flow dynamics at the joint get weird. You get turbulence, which leads to scarring and failure. The Miller cuff involves sewing a little collar of vein onto the end of the plastic tube before sewing it to the artery.
Like a gasket.
Exactly. It acts as a buffer, a shock absorber. It smooths the flow dynamics and makes the plastic graft stay open much longer.
It's amazing the tricks surgeons have developed over the years. Let's look at a fictional case to tie this section together. Meet Arthur.
Arthur is 65. He's a retired truck driver, smokes a pack a day. He tells you that when he walks 2 blocks to the news stand to get his paper, his left calf cramps up tight. He has to stop. He looks in the shop window, the classic shop window sign, pretending he's reading the headlines while the pain fades. Then he walks again, but at night, he sleeps like a baby.
What's our analysis of Arthur?
This is classic intermittent claudication. It is not critical because he has no rest pain and sleeps fine. The management here is conservative. We do not rush Arthur to surgery. We put him on a treadmill program, get him on a high-dose statin, and help him quit smoking. His risk of losing the leg is low, but his risk of a heart attack is high. We treat the whole patient, not just the calf.
Poor Arthur needs to toss the cigarettes. Okay, let's shift gears. That was the slow burn. Now we enter the danger zone. Section 4, the acute emergency.
This is a different beast entirely. In chronic disease, remember, you had years to grow those collateral side streets. In acute arterial occlusion, the lights go out instantly. The limb is unprepared. There are no side streets.
And there is a strict time limit here.
Time is tissue. The golden window is 6 hours. After 6 hours of no blood flow, irreversible damage starts. And it happens in a specific order. Nerves die first. They are the most sensitive to oxygen lack. Then muscle. Then skin.
And we need to memorize the symptoms. The 5 Ps.
If you take nothing else from this deep dive, memorize the 5 Ps of acute ischemia. 1. Pain. Sudden, severe crescendo pain. 2. Pallor. The leg goes ghost white. 3. Pulselessness. You can't feel a pulse. 4. Paresthesia. Pins and needles. This is the nerve starting to suffocate. 5. Paralysis. You can't move the toes.
And paralysis is a very, very bad sign.
It's an ominous sign. It means the muscles are non-functional. It pushes the urgency from hurry to run.
Now, what causes this sudden blackout? The text distinguishes between embolus and thrombosis.
Think of the difference this way. An embolus is a rock thrown into a healthy stream. It's a clot that formed somewhere else, usually in the heart, maybe due to atrial fibrillation. It shoots down the aorta, enters a healthy leg artery, and bam, gets stuck at a fork. Sudden, dramatic, severe.
The thrombosis.
Thrombosis is silting up. It's a clot forming on a pre-existing plaque. It's the acute on chronic situation. The pike was already narrow and rusty. The flow was slow. Then a clot formed and sealed it off. Because the patient probably had some collateral circulation from the underlying chronic disease, the symptoms might be slightly less dramatic than an embolus, but it's still an emergency.
How do we triage this? The text mentions the Rutherford classification.
What's the traffic light system for the surgeon? Class 1, viable. The leg hurts, but there's no immediate nerve damage. You have time to image and plan. Class IA, marginally threatened. You have sensory loss, maybe numbness in the big toe, but no muscle weakness. Salvageable. Class IDUB, immediately threatened. You have a sensory loss, ANG, mild muscle paralysis. You cannot wiggle the toes. You need to be in the operating room now. Class 3, irreversible. The leg is dead, nerves and muscles are gone. The muscles feel hard and woody. Rigor mortis has set in.
And at class 3, you don't revascularize.
You can't. If you open the pipes to a dead leg, you wash all that acid, potassium, and toxins back into the body. It causes cardiac arrest. It's called reperfusion injury. A class 3 leg requires primary amputation to save the patient's life.
That is grim. So if we are in that treatable window, class 1 or 2, what is in the toolkit?
Step 1, heparin. Immediately. You need to thin the blood to stop the clot from growing, from propagating into the smaller vessels.
And then you have to get the clot out.
If it's an embolus, that rock in the stream, we use a device that absolutely revolutionized vascular surgery, the Fogarty catheter.
I read about this. Invented by Thomas Fogarty,
Yeah.
legend has it he prototyped the first one using a ureteric catheter and the finger of a surgical glove tied with fishing line.
That's the story. Before Fogarty, surgeons had to slice the artery open all the way down the leg to find the clot. Fogarty changed everything. The design is genius in its simplicity. It's a very thin, long tube with a deflated balloon at the tip. You make a small cut in the artery in the groin. You slide this tube down past the clot.
Through the clot.
Through it or around it. It's slippery. Once you are past it, you inflate the balloon, then you pull the catheter back. The balloon acts like a chimney sweep or a snowplow, dragging the clot out of the artery with it.
Simple and brilliant.
If it's a thrombosis, that silted up pipe, the Fogarty might not work because the underlying plaque is still there. In that case, or if there's a lot of debris, we might use thrombolysis.
Drano for the arteries.
Effectively, we inject a clot-busting drug like TPA directly into the clot to dissolve it, but that takes time, often 24 hours of infusion, so you can't use it if the leg is already critical, like a class at IAB. You just don't have 24 hours.
Okay, check-in question 2.
Ready?
We mentioned pain and paralysis in the 5 Ps. Why is paralysis in a cold leg such a much more dangerous sign than just pain? Pause and think.
The answer is paralysis implies nerve death. Pain means the nerves are alive and they are screaming. Paralysis means they've gone silent. It indicates deep, potentially irreversible ischemia. It changes the Rutherford class to immediately threatened.
We are in the final stretch, section 5, when the tissue dies. Gangrene and the diabetic foot.
This is where we see the consequences of failed treatment or, neglected disease. Gangrene comes in 2 main flavors, dry and wet.
Describe them.
Dry gangrene is mummification. The blood supply stops slowly, the tissue dries out, turns black, and shrivels up. It's often not infected. The body creates a zone of demarcation, a clear line between the living pink skin and the dead black skin.
It's autoamputation, essentially.
In a way, if it stays dry, it's stable. You can sometimes wait for it to fall off or trim it electively.
And wet gangrene.
This is the nightmare scenario. There is infection involved, putrefaction. The tissue is boggy, smelly, and oozing fluid. The redness cellulitis is spreading rapidly up the leg. There is no clear line. This leads to sepsis and death very, very quickly.
The text highlights the diabetic triad as the perfect storm for this. Why are diabetics so vulnerable?
It's a 3-pronged attack. 1, ischemia. They have the blockages we talked about, often in the deep tibial arteries of the calf. 2, neuropathy. This is the silent killer. They lose sensation. A diabetic might have a pebble in their shoe, walk on it all day, create a blister, and never feel a single thing. 3, infection. High blood sugar suppresses the immune system, so white blood cells just don't work well. The bacteria thrive in that sugar-rich blister.
So you have a wound you can't feel, on a foot that has no blood flow to heal it, and an immune system that can't fight the bacteria.
Exactly. Let's look at case study 2, Brenda.
Brenda is 70 and diabetic. She was prepping for her grandson's birthday party and was on her feet all day. She didn't feel a blister form on her toe. 2 days later, her toe is black, oozing fluid, and there's a red streak going up her foot. She feels feverish.
This is wet gangrene with sepsis. Unlike Arthur, who could just exercise, Brenda is a surgical emergency. She needs antibiotics immediately. She needs debridement cutting away the dead infected tissue to stop the spread.
Source control.
And she needs revascularization opening the pipes to save whatever is left of the foot. If you wait, she loses the leg. If you wait longer, she loses her life.
It's a stark contrast to the chronic presentation. The text also briefly mentions bed sores and frostbite.
Yes, bed sores are pressure gangrene, usually on the heel or sacrum in bedbound patients. The weight of the body squeezes the blood out of the skin. Frostbite is cold, injury ice crystals form in the cells, and the vessels spasm shut. Both result in tissue death that looks a lot like gangrene.
We have covered a massive amount of ground today. From the first cramp of claudication to the emergency of the Fogarty catheter. Let's summarize the key mental anchors for our listeners.
Sure, let's boil it down. 1, chronic disease is a slow burn. Look for claudication, which is relieved by standing, progressing to rest pain, which is relieved by hanging the leg down. 2, the sunset foot, pale up, purple down, that is your visual cue for severe chronic ischemia. 3, acute ischemia is the 5 PS. Pain, pallor, pulselessness, paresthesia, paralysis. You have 6 hours. 4, vein is king. When bypassing, nothing beats the patient's own vessel.
And my takeaway is the differentiation between arterial and spinal pain. That sit versus stand distinction, the shopping cart sign, is something you can use in clinic or even with your grandparents tomorrow.
Absolutely. It's a high-yield diagnostic tool.
A final provocative thought to leave you with. We talked about Larisha's syndrome, buttock pain, and impotence. It's a reminder that vascular surgery isn't just about plumbing. It's about quality of life. The ability to walk your daughter down the aisle, the ability to maintain intimacy, all of it relies on these pipes staying open.
It's humbling. And quick call to action, Chapter 61 has incredible diagrams of the Fogarty catheter pulling out a clot and the angiograms showing the collateral circulation. Go look at them. It really cements the mental image.
We will leave it there.
Ooh.
Keep the flow moving, watch your cholesterol, and see you in the next deep dive.